have that frenulum in your tongue. From that frenulum, your thyroid gland will go down through your thyroglossal duct. And like if it is remnant, then there can be a thyroglossal cyst, and this will appear as a midline swelling. Then what I think will happen is there is like a lateral part, anterior, and in the middle, the isthmus.
Mm.
That's what I
What
remember
what
from
anterior? I didn't understand what anterior lateral. Sorry.
anterior. Allah, see lateral, you have that two towers ತರ ಇರುತ್ತೆ ನೋಡು structure.
Uh,
So isthmus you have. That's all.
like
Like how do I put it? Yes.
the lobes, you mean, right and
Yeah.
left,
Yeah.
and this is the isthmus.
Yep.
Yeah. Okay. Tell. Hmm.
That
So wait,
is.
any thyroid swelling will present as a midline neck swelling.
Uh-huh.
Okay. So even if it's a goiter or if it's a thyroglossal cyst. Okay.
Mm-hmm.
Kaushik, you don't tell. How will you differentiate between the two clinically? Sai, you tell.
Which one?
All thyroid swellings present as a midline neck swelling, right?
Mm-hmm. Mm-hmm.
So how will you differentiate from a goiter or anything else, carcinoma, whatever, versus a thyroglossal cyst clinically?
Thyroglossal cyst, wait, all of them are midline,
Hmm.
and the thyroglossal cyst, it moves with deglutition, no?
Correct. Yeah. Why?
What?
Why? Why?
Because it's still connected to the base of the tongue.
Yeah, correct. See, basically the thyroglossal duct is connected to the tongue, right? And the
Yeah.
thyroglossal cyst is persistence of the thyroglossal duct.
Mm.
So it will move with wait. What did you say? Sorry, move with deglutition.
Yeah, swallowing or the protrusion of the tongue.
Protrusion of the tongue. Yeah, correct. Okay, correct. Kaushik, are you alive?
Yep. I
Yeah,
think it's
okay.
mainly like protrusion of tongue. No,
See,
swallowing will
thyroglossal
also.
cyst will all thyroid swellings will move with deglutition.
Yeah.
Mm.
Okay, but a thyroglossal cyst will also move with protrusion of tongue. That's how you differentiate that from the rest of the thyroid swellings.
Right. So
Yep.
this is specific to protrusion of the tongue.
Yeah, because it's also connected to the tongue, right?
Right.
Foramen
Right.
cecum, can you
Yep.
see? Okay. Yeah, so just remember that thyroid follicular cells are, you can still see my screen, no?
Yeah.
Yeah.
Yeah. Yeah.
Okay, fine. Thyroid follicular cells are derived from endoderm, but parafollicular cells arise from fourth pharyngeal pouch.
Mm.
Okay, so we'll see blood supply once of thyroid.
Mhm.
See, so basically you have superior thyroid and inferior thyroid artery.
Mhm.
Superior thyroid is a branch of,
External carotid.
and inferior thyroid is a branch of,
Thyrocervical tongue. Subclavian.
yeah, which is a branch of subclavian. Yeah, exactly. In a few people, you also have the middle thyroid artery. Not
Mhm.
always. In a few people.
Okay.
Mhm.
Yeah. Then nerve supply. Do you
Wait,
remember?
superior thyroid and inferior thyroid, right?
Yeah. Can you
Superior
see?
thyroid.
Mm.
Yeah, I can see superior thyroid is external carotid. Inferior thyroid is through
Sorry.
thyroid. Inferior thyroid
Inferior
is
thyroid is through thyrocervical trunk, which is a branch of subclavian.
okay. Yes.
Okay.
Mhm.
Fine. In some people, you have a middle thyroid artery also.
Okay.
In some people, not in all.
Okay.
Okay. Then this one venous drainage. Anyone remembers?
Mhm.
Like even in brief is fine.
Subclavian, no, wait.
Kaushik, you
Thoracic
buffalo. I
duct.
taught you, bro.
I know, bro.
At least something.
Sorry to disappoint, knowledge.
It's okay.
Mhm. Okay.
See, so you have superior veins will have a this one tributary, no? It won't
Yes.
have a branch, so it'll all drain into something.
Yeah.
1 second,
Inferior
wait.
vena cava.
Yeah, shabash.
Jugular.
So superior vena cava.
Bro, you know how you're telling. This is like if they ask you which branch is this artery a branch of, you'll be like iota. No shit.
I think it
Oh wait,
is.
wait, wait. 1 second. 1 second. Kaushik. Okay, 1 second. Just 1 second. I'm sorry for changing the topic. Kaushik, why does duodenal atresia cause non-bilious vomiting?
Duodenal atresia.
But why does duodenal atresia cause non-bilious vomiting? But what do you call esophageal? Sorry. Why does esophageal atresia cause non-bilious vomiting, but duodenal atresia cause bilious vomiting?
It's because bile will be there, no?
Exactly.
So
That's what I said. She wants an elaborate answer.
Bro, if I'm
wait, I
telling
will.
you it is bilious, obviously bile will be there.
She
What's
wants you to
the
elaborate according to the
nonsense?
anatomy.
Huh?
See, in your bile duct will drain in the second part of your duodenum. So if
True?
you
True?
through common bile duct, wait,
In the duodenum through?
common bile duct,
Yeah, bro.
uh,
CBD drains into duodenum through something
through that opening, no? What is that
called
called? Wait, I know this. It's not coming.
sphincter of Oddi.
Yeah, sphincter of Oddi.
Hmm.
Mm-hmm.
Yeah, so that's why all issues like proximal to that second part of the duodenum will
Mm-hmm.
have non-bilious vomiting.
Yes.
And everything from there in distal will have bilious.
Yep.
That's what you should say, not that bile is there. Obviously, I knew that. That's why I told you it's bilious.
Okay.
Donkeys,
Okay.
both of you are.
Mm.
So I was like, I told that only, it seems nonsense. Okay, tell. Venous drainage.
So, where does
Tell
it go?
something. Anything.
Jugular vein.
What?
Jugular vein.
No,
If
what?
you
Like, what? What about it?
external jugular.
It's internal jugular.
Oh shit, so close.
Yeah. Wow, shabash.
Okay.
Okay, see, so I will change my screen. You can see, no, still?
Yeah.
Mhm. Yeah,
Yeah, so now basically, so you have superior thyroid vein and inferior thyroid vein. Is it too thin? I will try to.
we can see.
Okay, superior thyroid and inferior thyroid, which together drain into IJV.
Okay.
Okay. Sorry,
Mhm.
superior and middle. I'm so sorry. Superior and middle, which basically drain into IJV.
Mhm.
Okay. Then
Okay.
you have the inferior thyroid vein of both the sides, which together drains in brachiocephalic.
Okay.
Okay. I'll repeat.
Mm.
Superior and middle thyroid. I'm so sorry. Superior and middle thyroid drain into IJV. Inferior thyroid drains into brachiocephalic.
Mm. Yeah.
Okay.
Mhm.
Remember. Superior and middle thyroid vein of one side will drain into IJV of the same side,
Okay.
and superior and middle of this side will drain into IJV of this side, right?
Yep.
Mm.
But inferior of both together drains into brachiocephalic.
Okay.
Okay.
Got it.
Yeah. Then nerve supply, please. At least this.
Superior thyroid and inferior thyroid. No?
I'll slap you.
Wait. Recurrent laryngeal nerve
Okay.
and uh, what else is there too? Recurrent direct laryngeal nerve.
I'll slap you. I'll throw something on you. I'm very serious.
One is correct, I know. Okay. Other I forgot.
Recurrent and external laryngeal, bro.
External laryngeal.
Hmm. Bah, Kaushik, you write one book, bro. I'm really telling you.
See how bad my memory is, dude.
It's okay. We have all been
Mhm.
there. I'm too much
Revision,
showing off
revision.
now, but
Mhm. Recurrent and external.
yeah, bro. Why can't I put yellow, Kaushik, on this one note?
You can.
It's not
You
coming
selected
only.
yellow only. More ink.
See,
That's why.
yellow. Apply.
Yeah, it would have come. It hasn't come.
It's coming in black.
Okay.
Okay, fuck it.
Mm,
I'll not waste my time now. Okay, see. So you have external laryngeal and recurrent laryngeal. Okay.
yep.
So external laryngeal. So wait. You have the artery. I didn't draw the artery. Superior thyroid is a branch of fast.
Which one?
External thyroid.
Yeah. And inferior.
Thyroid trunk.
Yeah. Yeah. Very good. Okay. So this is superior thyroid. Imagine this is superior thyroid artery and this is inferior. Okay.
Yep.
So superior thyroid and now you have your vein. Sorry, you have your nerve.
Mm-hmm.
Okay. External laryngeal closer to the gland. Is it away or near the artery?
Wait, closer to the gland, it is near the artery.
Are you sure?
Yes. No,
Yeah.
wait.
Yeah. Yeah.
Yeah.
You're right. You're right.
Yeah.
Before you change.
No, that is why they do that operation. No,
What?
like they will make sure that it is.
Yeah. So that's why whenever you're ligating the artery, it's better to ligate it closer to the gland because if you do it away, you can injure the nerve.
Yeah. Wait, what did
Okay.
I say?
You said
I
the
told
correct thing
wrong.
only.
I told closer to the gland, it is away from the artery.
Yeah. Away from the gland, it is closer to the artery.
Yep. Yep.
Correct.
Mhm.
Okay. Yeah. Basically, yeah, bro. That's all. Okay, fine. Now, tell. What was I telling? So we're done with anatomy. Is this much? I think should be okay.
Yes.
Okay, fine. Now tell. Sai, tell thyroid hormone synthesis. Hello.
Yeah. 1 second.
Hello. Don't see and tell. What the fuck?
Huh?
Don't see and tell.
No, I've made notes separately for this.
No, don't see and tell.
Okay, okay, fine,
Tell
fine.
from your
What?
memory.
Okay, okay. Whatever I know, I'll just tell you.
I made notes for this. It's in Buffalo.
Okay, see,
Mm.
thyroid hormones are the basically two, T3 and T4,
Mm-hmm.
triiodothyronine and tetraiodothyronine.
Mm.
So
Okay,
these are
first.
synthesized from uh, tyrosine and iodine.
One second. Before that,
Mm.
your thyroid gland has two types of cells. What are they called?
Fine.
Uh,
So you have follicular and
Follicular.
parafollicular.
Parafollicular C cells.
Yeah,
Mm.
follicular and parafollicular. So which one cells? Which one produces what?
The follicular cells produce. Uh,
Follicular is inside, no? Parafollicular, that is little outside. So I think in follicular you'll have T4, that iodine and all.
You tell,
eh,
tell.
T4.
Okay.
And parafollicular bandaga, it will be that deiodinization or something will happen.
I think no, actually, from my understanding, I think all of this, the hormone synthesis and everything goes on in the follicular cells.
Okay.
And
What does
parafollicular cells,
parafollicular do?
C cells are it's for calcitonin, right?
Yeah. Okay. So both T3 and T4 are produced by follicular cells. Parafollicular cells produce calcitonin.
And the TBG is also produced in follicular cells, right?
Everything is in the follicular cells. The whole
Mm.
T3 T4 synthesis happens in the follicular cells.
Mm.
Okay, start. And before that, so what do you require to produce this? What is required? Like
Thyroid binding globulin
no, leave
and
all that.
iodine.
That and all is already there. Huh? You need, yes, correct. You need iodine.
Iodine.
Okay,
Okay,
that's
iodine.
so.
One second. I'm so sorry.
Yeah.
Iodine
No, no, no
is
problem.
taken in the dietary form. In which form?
I I-130.
A. That's
No, that's a
radioactive. What
radioactive
is
Radioactive.
it?
isotope. It's taken
It's
in the
in the
form of iodide.
reduced form.
Okay.
Yeah, iodide form or the reduced form. Okay.
Mhm.
And you need an amino acid called tyrosine,
Tyrosine.
Okay.
which is present in.
Mm,
Oxidants.
millets.
Thyro.
Yeah, thyroglobulin. Yeah.
Ah, okay, yeah.
Sorry.
It's okay, it's okay. Yeah, yeah, fine. Okay, start now. Start from the first step of synthesis, okay?
Okay. So since iodine in the dietary form is present as iodide,
Mm-hmm.
so first this iodide is has to undergo oxidation
Mm-hmm.
to be converted to I2.
Okay.
So this I minus is present in the plasma,
Yes.
and so this has to enter the follicular cell,
Mm-hmm.
and it's transferred to the follicular cell through this the sodium uh, NIS import. Yeah. So the sodium and iodide.
Okay, fine. I'll tell.
Yep.
I'll ask you after this. If you people don't tell, I'll kill you. Okay,
Mm,
see. So you have a follicular cell. Okay, tell me if I'm going too fast or anything. Okay,
Okay.
you have a this is your follicular cell. Assume. Okay. On this side you have your blood vessel.
mm,
Yep.
Okay. Now always remember blood vessel for B. So the end of a cell closer to the blood vessel is called the basolateral end.
Yep.
mm.
The other end is called the apical end.
Okay.
This is fine.
Yep.
Okay. So now, if so now what? Sorry. Yeah. So now basically what happens is, like he told, iodine is present in the reduced form, which is I minus.
Yep.
Okay, that needs to be that is taken up by the follicular cell through NIS, which is sodium iodide symport. So what does that mean? Along with iodine, even once sodium comes in.
Yep.
Okay. Since it's a symport, no ATP is required.
Okay.
Okay. Now what happens here? Okay, so before all this, okay, leave it. Yeah, I'll start from here. We'll talk about that later. Okay, so this is sodium iodide symport. Okay. Now what happens after that? Uh, Sai, can you tell now what is the next step?
Uh, yeah, I'll just recollect it.
Yeah.
Monoiodine oxidase or something is there, no?
No. So this I minus goes out.
Oh,
Okay,
okay.
it crosses the apical membrane. So if you're taking out one negative charge, you have to give back one negative. So that is chloride.
Okay.
Okay. So this is called iodide chloride antiport.
Wait, that is this is happening in follicular cell, no.
Yes. Yes.
Okay, got
Okay.
it. Mm-hmm.
Okay. See,
Okay.
I'll just show you. This is a thyroid follicle. These are your follicular cells.
Yep, yep.
And in the middle, you have the colloid.
Mm,
Yes.
Okay. So the hormone is stored in this colloid. And then
Right.
it's released when required.
Yep.
Okay. Fine. So till here is fine. Iodide chloride antiport.
yeah.
Yes.
Till here is fine. This is also called pendrin.
Oh, I've
This is
heard
also
this.
called pendrin. I'll tell you why it's important later.
There is one disease.
Yeah. Kaushik always guesses me right. Okay, fine. So this first step is called iodine uptake.
Mm-hmm.
Okay.
Mm,
Okay.
So very simple. One iodine from your dietary form of iodine is a reduced form, which is iodide form, that is
Mhm.
taken up by the follicular cell along with sodium with the help of sodium iodide symport. So if they ask you sodium iodide symport is present on which end of the cell, you should say basolateral end.
Okay.
Okay.
Yep.
Now,
Mm.
iodine and chloride are exchanged through a channel present on the apical end of the follicular cell, which is called iodide chloride antiport, also known as pendrin.
Yep.
Mm.
Is this okay? So
Yeah.
that's till now what has happened. Iodine has been taken up. That's all.
Mm.
Okay. Now the second step, what happens is this iodine, which is taken up. What happens, Sai?
So the tyrosine is bound to thyroglobulin.
Mm-hmm.
So this iodine is combined with the tyrosine.
No, no, no. Before that, you have an enzyme called thyroid peroxidase, which
Yeah,
basically oxidizes the iodine to form
oxidation.
IC.
Yes, I do. Yeah, yeah.
This step is called
Oxidation.
organification.
This is oxidation, right?
No. Okay, maybe it's also called oxidation. It's called organification, from what I know.
Yeah, it's
Okay.
organification because it comes into organic iodine, no?
Okay.
Mm-hmm.
Yeah.
Mm.
Now tell what you were telling.
Yeah. So the tyrosine that's bound to thyroglobulin
Mm-hmm.
binds with this I2
Mm-hmm.
and forms MIT and DIT. That's
DIT if two iodine molecules combine.
mm,
Okay.
monoiodotyrosine and diiodotyrosine.
Okay.
So after this, there's a coupling reaction that
Mm.
takes place next. This is
Mm-hmm.
also uh, brought about by thyroxine peroxidase.
Yes. So what is
So,
coupling?
so one MIT and one DIT together form T3,
Mm.
and two DIT together form T4.
Mm.
And this is still bound to thyroglobulin.
Okay. There's one more thing.
Mm.
So for here you have MIT plus DIT, which gives rise to T3, right?
Mm.
Mm-hmm.
So if DIT combines with MIT,
Reverse T3.
yes, you get something
Mm.
called reverse T3, which is basically inactive.
Mm.
It's an inactive form of thyroid. Yeah, continue.
Yeah. So the following the coupling reaction, the T3 and T4 that's formed is still bound to thyroglobulin. It's in the
Okay.
bound form, not the free form.
Yes.
So this T3 and T4 they undergo proteolysis,
Mm-hmm.
and following proteolysis, they're in the free form, which is released into the plasma.
Yes. That's all.
Hmm?
That's all.
Mm. Mm. Uh, Most of the hormones present in the plasma T4.
Mm-hmm.
Okay, the 5 dash deiodinase converts T4 to T3.
Yes.
Mm.
Okay. This is really important.
Mm.
Okay. So you have something. Okay. So now basically I'll tell you. Okay. So we'll go again stepwise. Okay.
Yeah.
Mm-hmm.
So the first step, what happened? Iodine uptake happened.
Mm.
Mm-hmm.
Kaushik, you will tell her.
Yes, I'll tell.
Yeah. Just tell the first step.
So basically, you'll have I minus, that is your I minus that is consumed in
Yeah.
your plasma. This is in your blood vessel.
Mm-hmm.
Then you have the follicular cell. If it is towards it, it is basolateral. So iodine will enter through your basolateral through sodium iodine symport,
Mm.
and this is passive. Then after it enters, then it will exit. That
Mm.
is through sodium chloride antiport.
Yes.
Sorry,
Iodide chloride
iodine
what?
chloride antiport.
Mm.
Okay, once you have this, then your iodine will go to get organified through TPO,
Yes.
tyrosine
Wait,
peroxide.
wait, wait. What? Stop. Just one
Yeah.
second. Stop. Okay. So this sodium iodide symport.
Hmm.
Okay. It's a type of what transport? It's a type of secondary active transport.
Secondary active,
Okay. And where did I tell you the thing was present? The receptor. Sorry. The
basolateral.
channel
Basal.
basolateral end of the follicular epithelium. Okay. So also remember, it is not only seen in the thyroid gland, it is also seen in parotid, salivary, mammary gland, and placenta.
Parotid. Which one? This NIS,
NIS, yeah.
okay. NIS
Parotid,
is
salivary, mammary gland, and placenta.
okay.
Okay. Now wait, I'll ask a question. Sai, you tell me. Suppose, so what is, by the way, what is the recommended dietary allowance of iodine?
Wait, some 10 grams, huh?
For whom? 10 grams
Milligram.
per month, year, decade.
Uh, it's different for, I don't know.
Yeah. So it is different. See, 0 to 5 years is 90 microgram per day.
Okay.
Okay. 6 to 12 is 120. More
Okay.
than 12 is 150. For pregnancy and lactating women, it is 250.
6 to 12 is 120. More than 12 is
150.
50.
Pregnancy and lactating women, it is 250.
Okay.
Okay. Sai Ovitas, no?
Yeah.
Yeah. Okay, now suppose I eat, so I'm more than 12 years, right? So I'm supposed to be eating 150 microgram per day. Assume I eat more than that.
Mm-hmm.
What will happen? Sai, you tell.
Sorry. You said more than your recommended dietary allowance, no?
Yeah.
Mm,
There will be
this is
hypertrophy.
considering the euthyroid state, no?
Yeah.
The Wolf-Chaikoff effect comes into play.
Yeah. So what happens?
Mm, so Wolf-Chaikoff effect is uh, so when there's excess iodine,
Hmm.
the function of thyroid peroxidase, uh, basically there's a reduced production of T3 and T4.
How? Okay, I'll tell you. See, Kaushik, do you know?
I know there are two, okay. Physiological is Wolff-Chaikoff, the other one is Jod-Basedow.
Ah.
Right. I think in Wolff-Chaikoff, what happens, there is more iodine, right? Because there is more iodine, there will be less, I think there is like limited action,
Okay.
limited TPO.
In very very simple, you both are right.
Mhm.
When there's more iodine, hormone synthesis is inhibited. My question is
Mm.
how? It basically inhibits this channel.
Yes.
Okay.
Mm.
Okay.
But for how long? Just transiently for about 5 to 7 days.
Okay.
Okay. It inhibits that channel. That's all. Till escape occurs.
Mm.
That is called Wolff-Chaikoff effect.
Okay.
Okay. Fine.
Mm.
This channel is also inhibited by perchlorate and thiocyanate. Okay.
Mm.
Yeah.
Okay. Fine. Now the step two, Kaushik, was okay. Fine. Since he already told, was this iodine and chloride antipode,
Okay.
which is also called pendrin. This is present in the thyroid. I'll tell you why that's
Kidney.
important. And it's also present in the inner ear.
Uh, sensory
Okay.
neural hearing loss you'll get, no?
Yeah. So if there is a mutation to this particular channel, the patient will have goiter along with sensory neural hearing loss. This is called Pendred syndrome. Hello.
Yep. Dude, why is there goiter?
Why not?
Like goiter here? Because of lack of iodine.
Mm-hmm.
Iodine deficiency, right? So
Only
basically,
what is goiter?
it can be because of both, no? There is,
Goiter is the general term used for enlargement of the thyroid.
yeah.
Yeah. Lack of iodine is one cause.
Mm.
Yeah,
I mean,
tell.
you'll have others also, no, like multinodular goiter, cold.
Yeah. So if there's a mutation to this channel, if this channel
Mhm.
is not functioning, this
You
exchange
can,
won't happen.
yep.
So your iodine will just remain here.
Okay.
And thereon thyroid hormone synthesis will not occur.
Mm-hmm.
So your thyroid follicular cells will try to multiply more to compensate for the lack of this one.
Oh,
Therefore, there'll be goiter.
okay. What is the other scenario where you'll have goiter?
As in,
Is there any, is it because one is iodine, right?
mm,
This, what is the other mechanism for goiter? I did not
see,
know this follicular cells will hypertrophy like this.
the thyroid follicles will hypertrophy.
Yeah, makes sense.
Hmm.
Because it'll try to produce more because it'll feel like it's not producing, right?
Yeah, and then in another state, suppose a patient is already hyperthyroid
Yes.
and has not like for whatever reason he is hyperthyroid and not been the thyroid hormones are not under control.
Okay.
Can that lead to goiter?
Yes.
How?
I don't know. I think it is like because it's producing more, like there is more stimulus
Yeah,
to
there's more
produce creatine.
exactly.
Okay,
So
that's
you
how
can
it
have a
works.
thyroid enlargement due to anything. That's why you have to first
Okay.
do a thyroid function test to look for what is the thyroid status of the patient
Okay.
at the time. Sai, you can't
Mhm.
stay this quiet.
No, I'm listening.
I need to know that. So
Okay.
participate in the
Okay.
conversation.
Yeah. Okay.
Got
Huh.
it.
Okay, fine. Okay, so now this is fine. So then the next step was organification,
Yes.
right? Where thyroid peroxidase converts the reduced form of iodine into I2. Okay.
Mm-hmm.
Thyroid peroxidase is inhibited by name two drugs.
Amiodarone.
Mm.
Uh,
Correct. Phenytoin.
Thiouracil,
Ah,
propylthiouracil,
propylthiouracil. Okay, what else?
One. Um, one thiazide. Methimazole. Albendazole. Okay.
Okay, so these drugs are probably used for.
hypothyroidism.
Yeah,
Hyper, no?
Hmm.
he said that only, bro.
Okay.
Hyper. That's what you
Yes.
Yeah,
said, no?
hyper.
Hmm.
Yeah, hyper.
Hyperthyroidism. Okay.
Hmm. Hmm.
Okay, Kaushik, next step.
Then you have iodine combining with tyrosine
Mm-hmm.
in the then it will form either monoiodothyroxine or diiodothyroxine.
Monoiodotyrosine.
Tyrosine.
Ah.
Monoiodothyroxine or diiodothyroxine. Then MIT plus DIT will give T3. Then
Hmm.
DIT plus DIT will give T4.
Yeah. 1 minute. Where is tyrosine derived from?
Uh, Vitamin B. uh, I know this. B6. Thyroxine.
My life.
Triangulobulin.
Yeah. This is present in the colloid.
Colloid, okay.
Okay. Fine.
Mm,
Yeah, tell me. Yeah. Then the next step was coupling.
yes.
Okay. Yeah.
Mhm.
And then hormone release
Okay.
followed by deiodination.
Yeah.
Okay. One thing. This deiodination, very interesting. Okay. It
Mhm.
is inhibited during acute infection
Mhm.
uh, or any systemic illness.
Yeah.
Okay.
Mhm.
It's also apparently inhibited during fasting. This I really am not sure if it's true. I'll tell you why. So basically, during these conditions, you should not do a TFT. Why?
Artificially, it will be lower, no?
What will be lower?
Your T3 will be lower.
T3 will be lower. Yeah, T3 will be lower, or your T4 will be higher.
Yes.
Okay, it's called sick euthyroid syndrome.
Mhm.
So the patient is basically euthyroid, like clinically,
Okay.
but there's a deranged TFT.
Mhm.
fasting, why I'm not clear is normally thyroid function test is given in fasting only.
Yeah.
Yeah.
So that's why I don't think this is right. Rakesh Nair Dumpfuck told.
Mm.
Okay, fine. This is fine.
Yeah.
Yeah.
Okay, fine. I'm
I think
sorry.
it is prolonged periods of fasting, dude.
Maybe.
It's not like one overnight fasting.
Maybe.
Oh, you
Hmm.
know what? Like apparently, if you if the patient has had food and then they do like thyroid test, that
Mm-hmm.
time your TSH also will be very high.
Mm.
Very high meaning it will be one of my friend did, it was 11.5. And then when she did during fasting, it was 3.2.
Oh, that much difference.
That's
Oh,
a lot, right?
yeah. But you know, a lot of like a few consultants, like I'll find out about this. A few consultants of mine, right?
Mhm,
They get TFT done without fasting. Because sometimes a patient would have come like to the hospital after eating.
mhm.
Okay. Will probably require OT or something.
Uh,
And they need to do thyroid profile if the patient is hypothyroid or whatever. They
mhm.
just do it off. And they're like, there's apparently a way to interpret TFT differently if the patient has given it after eating.
Oh, okay.
Yeah, we should learn how.
Yeah, I'll ask.
Mhm. Okay, this is fine, no?
Mhm.
That's all this whole page is, Kaushik. You were wondering.
Yep, yep. It.
Okay,
Thank you.
fine. Yeah. So we're done with anat, we're done with physio.
Mhm,
Fuck, sorry. Huh. Tell. Okay, yeah, yeah. Now, one second. Okay, Sai, you tell like regulation of this thyroid hormone synthesis. Is he there?
Yeah.
Tell.
Yeah. So, uh, okay. So there's the hypothalamus, the anterior pituitary, and the follicular cells.
Mm-hmm.
So the hypothalamus releases a hormone called TRS, that's thyroid releasing hormone.
Mm-hmm.
This in turn, uh, 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 how do I put it? So the thyroid releasing hormone stimulates the anterior pituitary,
Mm-hmm.
from where the thyroid stimulating hormone is secreted,
Yes.
and the
That stimulates thyroid follicular cells to release the
thyroid follicle.
hormone.
Yeah. Yeah.
That's all.
Mm,
Okay.
mm,
So now my question.
mhm,
So you have the TSH here, right?
yep.
mm.
The TSH will go bind to its receptor,
Yes.
right?
Mhm,
TSH goes and binds to its receptor.
yep.
Now, and then after that, everything continues.
Mhm,
Okay. Now, see, like they've shown here, dopamine and this glucocorticoids, they basically compete with TSH.
mhm.
Sorry, they compete with yeah, they compete with TSH and bind to its receptor like competitively.
Okay.
Right. So
Mm.
therefore inhibiting thyroid hormone synthesis.
Mhm,
Okay.
That's how they work. Okay. Now my
Mm.
question is so basically the thyroid hormone synthesis begins at the hypothalamus.
mhm.
Yeah.
Right.
Mm.
But remember the thyroid gland. Okay, I will not. Let me put it this way. So the hypothalamus is basically what is responsible for thyroid hormone synthesis, right?
Okay.
Yeah.
Which basically stimulates the anterior pituitary. Till here is fine.
Yep.
Mm.
Now my question is: suppose a patient has adult pituitary insufficiency, right?
Mhm.
Suppose a patient has adult pituitary insufficiency.
Okay.
Will he be hypothyroid?
If you are
If yes,
asking, will
why?
he be?
And if no, why?
You're asking, will he be? Most
Yeah.
likely.
Huh?
Uh, See, in when you think about this one, no, the Sheehan syndrome in anterior pituitary hemorrhage, there will
Mm.
be reduction in TSH, but in that I have not seen that patients will have thyroid disorder. So I don't think so. It will be there.
If yes, why? If no, why?
I think it's no.
Why?
Um, why?
Sai, what do you say? Yes or no?
I'm really not sure.
T- Take a wild guess. Okay, I will
There
not
are
annoy.
others. Wait, there
I
are
will not
others.
annoy.
There are other substances which can mimic the action of TSH, cortisol or something, no?
Mimic the action of TSH? No.
Antibodies. If it
Antibodies too?
antibodies to those receptors you'll have, no, in that autoimmune condition.
That's
I said
Graves,
the
I think.
patient has. I said the patient has pituitary insufficiency, not some autoimmune condition, Buffalo.
Pituitary insufficiency. No, dude, you will not have. I don't know why.
Okay, you are right. The patient will not have. The
Uh,
reason is basically the thyroid gland is also capable of producing some amount of hormone by itself
oh, okay.
without help from the hypothalamus and the anterior pituitary.
Mm.
Okay, so because of that, a patient with adult pituitary insufficiency will not have hypothyroidism. Remember.
You know how I remembered that? It's
Mm.
because I told you, no, Sheehan syndrome.
Sheehan syndrome.
In that, I know for sure there is no thyroid disorder.
Hmm.
So that's why I was like, okay, it's not that.
Very good. Okay, somehow your answer was right, anyways. So this was that thing which we learned.
Okay.
This looked a little complicated to me. No offense.
Okay. Thyroid gland.
The this one that we learned, hormone synthesis.
Mm. Yes.
Okay. Okay. Peace. Shall we go ahead?
Yes.
Okay. Very good. Huh. So now tell actions of T3 and T4. Kaushik, you tell T3. Sai, you tell T4.
T3 is the main, it has main functions. No.
Mm-hmm. Like.
So it will increase metabolism. Then it will, what else don't increase T3 metabolism? Then what else? Growth hormone.
Mm-hmm.
7 I did not know that. Lipolysis, yeah. Lipolysis.
So basically, T3 is the one that's more active, right?
Mm.
So basically, everything it increases.
Yep.
So it causes bone growth, increases BMR, increases blood sugar, breaks
Mhm.
down lipids, so
Mm.
that it increases lipolysis, stimulates surfactant production.
Yep.
Fine.
Yes. I think we
Yeah.
should remember, like in hyperthyroid condition, what all might happen.
Exactly.
Yes.
Exactly. You can
Yeah.
remember however you want. Either remember reactions of the hormone and then be like, that's why in hypothyroid
Yeah.
condition, that's all that what happens. Otherwise, if remembering symptoms is easier for you, you can remember that way also. Whatever
Yeah.
works.
Okay.
Okay, fine. So what does T4 do? Sai, is he there?
Mm.
It
Yeah.
reduces the
Yeah.
information of T3.
Wow. Mm. Then why do we measure T4 only then?
It's there in body. It'll act. I think it's mainly that negative feedback. It reduces uh, I mean, TSH production.
Uh,
Reduces.
TSH production. TSH release. Thyroid releasing globulin. I think it reduces thyroid releasing globulin.
See, remember one thing. Very,
From what
very.
I
Yeah, yeah, tell, tell.
Thyroid releasing globulin.
sorry, from what I saw in the video of the Birds and Beyond, they
Mhm.
say that the uh, T4 of the thyroid hormones present in the body, over 90% are in the form of T4. Only
Yes.
10% of it is in the form of T3.
Yes. So
So,
don't you think it should have a function?
mm, mm, I don't know.
See, basically, so your hormones are basically stored in the thyroid colloid, okay,
Mm,
and they are released only like as and when required. So
mm,
Yeah.
most of the form is present in the T4 form, which by the deiodination is converted to T3, and therefore it is uh, used. T3 is what basically works on effector organs,
mm,
okay, like your brain, bone, whatever,
Mhm.
BMR, etc.
mm.
Okay. Now the point is, what does T4 do? Okay.
Yeah.
T4, just remember, has a longer half life.
Okay.
So how is that useful for us?
It can stay for longer, no? Like
Yeah. So so
you.
when we are treating a patient with hypothyroidism,
So
in
you
our
should look for
pharmacological
T4.
drugs, we will use
T4
T4.
yes, because it has a longer half
longer
life.
half-life. Okay.
Did it make sense?
Yes.
Okay. Excellent. Okay. Um.
And uh,
Yeah.
yeah, and another thing that they mentioned in the video was the reason why T4 is given and not T3 isn't given is because T3 is absorbed rapidly from the intestines.
Mm. Oh,
So
okay,
this can
okay.
cause hyperthyroidism.
Hyperthyroidism. Yeah, okay. Hmm.
Basically, like because it's short acting, it will cause hyperthyroidism.
Yeah, yeah,
Yeah, yeah.
yeah.
In short.
Okay.
Mhm.
Made sense. Okay.
Is there any condition where there is decrease in phi dash thyroid DIO? What does that do? Diiodox. What is that?
Deiodinase.
Deiodinase.
I'll belt you.
Is it there?
It's not even, we didn't even read it 5 minutes back. It doesn't remember the enzyme name of it.
Deiodinase. Didn't
Mm.
flash to
No,
it. Okay.
I mean,
It's
I
not
don't
there.
think there's a disease. I've not heard of one at least.
Okay, fine.
Okay,
Because
but where
you're
do we, how do we, what all drugs do we use to, like, inhibit deiodinase?
Propylthiouracil, methimazole, carbimazole.
Beta blockers, propranolol.
Wait, deiodinase?
Mm.
you are
Yeah,
telling for this one.
Oh, he was
Uh,
selling for thyroid peroxidase, no?
yes.
But he was still not wrong. Steroids,
PT also include.
propylthiouracil, propranolol, and amiodarone. Kaushik, amiodarone inhibits deiodinase, not thyroid peroxidase.
Deiodinase. Okay. It
Okay.
also mimics iodine action.
Mix iodine. Yeah, yes.
Yeah. So it can cause both
Hmm.
hyper and hypo.
It can cause. Yeah, yeah, yeah. Amiodarone, no.
Yeah.
Yeah, yeah, it can.
Mm-hmm.
Okay.
Nice.
Um, 1 second. 1 second. I'm so sorry, guys. 1 second.
So what all can inhibit deiodinase? Propylthiouracil, then glucocorticoids,
Yeah,
amiodarone.
beta blockers.
beta blockers like propranolol.
Okay.
Okay. Okay. Yeah. So that's basically about thyroid hormone. Okay. It made sense, no?
Yes.
Mm,
Okay. See, this I'm not sure how useful it is, but anyway, let's just read it. Thyroxine binding globulin (TBG) binds T3 T4 in the blood. The bound form
Yes.
is inactive. We know that. There is increased TBG in pregnancy, OCP use, etc.
Mm-hmm.
Because there's increase in estrogen, which basically inhibits. Which basically increases the amount of TBG.
Mm-hmm.
So there is an increase in the total amount of T3 and T4.
Mm.
Okay.
Yeah.
Reduce in TBG is seen in this we know, right? Steroid use in nephrotic syndrome. Why nephrotic syndrome?
There is protein loss.
Yes. Yes. That's all. You have amino acid loss. Globulin will therefore be lost.
Mm.
Yes.
That's all. Okay.
Yeah.
So that's why since thyroid binding globulin is increased in pregnancy and OCP use due to increase in estrogen,
Mm-hmm.
that's why there is a increase in the total
Hypothyroid.
T3 and total T4. Hello.
Yes,
Yeah.
yes.
Yeah, it's the total T3 and total T4, not the free T3 and
Treaty.
free T4.
Mm.
Total T3, total T4 is what is present in inside before proteolysis, before hormone release happens.
Yeah.
Yes.
Right.
Mm.
So
Mm-hmm.
that there's a total increase in that.
Mm-hmm.
Hmm.
Okay.
But in pregnancy, in a hypothyroid patient in pregnancy, they usually say you should increase the dose.
Yeah,
Why?
this is the reason, no? See, your inactive T3, T4 is getting increased, but not the free T3 and free T4.
But why?
That they just told, right? Thyroid binding globulin will increase. So it will capture more of
Oh,
your
to
free
capture
T3
more
and
of
free
it. Yeah,
T4.
yeah, yeah,
So
yeah,
that's why you
yeah.
need to give.
Hmm. Got it. Yes. Okay, fine. This is okay, no?
Yeah.
Yeah.
Okay, peace. Okay, so now we learn about hypo and hyperthyroidism. Okay, so tell one of you tell hypo, one of you tell hyper.
In hyperthyroidism, basic metabolic rate will be that
Mm.
increased. So there will be weight loss, there will
Mm.
be intolerance to heat, then
Mm.
there will be exophthalmos,
Mm.
then what else?
Tell of now that you told you tell of all the eye signs.
Lid lag, uh,
That's called
lag ophthalmos. I'm right, no?
no.
Dalrymple sign.
Dalrymple is not lid lag.
ಅದು ಮೇಲ್ಗಡೆ ಇದು the wrinkling will go, no? What is
You'll
that?
make me also for me. Mm.
I'll tell you. Eye signs, no.
Wait,
First of all, there will be protrusion of your eyes.
that
That
is
is
exophthalmos. Excellent.
exophthalmos.
That is because of
Because of
what?
that, there will be accumulation of your fluid in your orbit.
I'll slap you.
Periorbital edema.
No.
What else?
If it is okay, wait. I'll ask you a simple question. If a patient has exophthalmos, if you
Hmm.
treat the hypothyroidism somehow,
Hmm.
will the exophthalmos settle?
I don't think so.
If it is edema, it should settle. Resorption of that fluid should occur.
Yes. Yes.
It doesn't happen, no.
Yeah.
Why?
So it is not edema. So it
What is it
is
then?
uh, fat.
Ma, just now you told there's weight loss. Suddenly, only behind the eye alone, fat will accumulate.
Uh, like, what is it? Not fat. There is some accumulation with protein.
It's glycosaminoglycans.
See, there is some accumulation. Okay. Accumulation of glycosaminoglycans.
That causes what
It's an
protrusion of the
osmotic
eye, which is
agent.
called exophthalmos. Yeah. Now continue.
Then, because your eye is protruding, you don't
Mm.
need to use your forehead a lot. So that wrinkles will go.
The um what is it called? Transverse wrinkles on the forehead. That sign is called what?
Barrier sign.
Huh?
Oh, no.
You make up something.
No, I forgot.
Sai, you know.
No, don't.
Dal Trimple. Wait, what is that thing? Is that no
Uh, what? What?
Dal Trimple? I told that is there. Staring sign. Some stare is there. No.
Bro, why, bro?
Okay, leave it. You tell.
You'll make me forget whatever I know.
Darius. Darius is not there. Huh?
There's nothing like Darius. What is Darius?
Okay, fine.
Okay, tell.
No, I have not.
Dalrymple sign is lid retraction.
Okay.
Mm. So basically, yeah, like what he said, you have first, you have protrusion of the eyelid.
Okay. Yeah.
Yeah.
You have protrusion of the eyelid. Okay.
Mm.
So first, because so that's exophthalmos,
Mm-hmm.
right? Now, because of that, yeah, because of that, there is loss of wrinkles on the forehead, transverse wrinkles on the forehead.
Yep.
Mm.
Okay. That sign, this Kaushik idiot made me forget. Oh. Okay, I'll remember in 2 minutes. I'll tell you that time. Okay. Now, then you have something called lid retraction. Okay, which is called Dalrymple sign.
Mm.
Okay. Then you have something called Stellwag sign, which is infrequent blinking.
Yeah.
Okay.
Mm.
Von Grafe sign is lid lag. So basically, what happens is because the eyeballs are protruding, if the when the patient looks down, right, the eyeball moves quicker compared to the upper eyelid because it needs to cover a larger curvature.
Yeah.
That's called lid lag. So basically, when the person is looking like from up to down, you can see the upper part of the sclera, which is normally not seen in people.
Okay.
That is called von Graefe's sign.
Mm.
Fine.
How
Okay.
I remember it is basically like because see the eye is protruded out, right? So
Mm.
if you want to look up, normally your lid you have to lift your lid, or else you'll not be able to see. But because this eye is protruded, you don't have to lift your eyelid, and you
Mm.
can see like that. So your vision field of vision will be better.
Yeah.
Right? That is one graphe, no? One
Yeah.
graphe sign. Okay.
Okay. Yeah. Then
Mhm.
tell. Yeah. So the basically the patient will have. If you go system wise, you can tell. No.
Yes.
There's basically increase in everything.
Mm-hmm. Hyperthyroidism, metabolically, heat intolerance, sweating, weight loss.
Mm.
Then ocularly, Graves' disease.
Mm-hmm.
That is periorbital. See, I've told periorbital edema. Periorbital edema, exophthalmos, lid lag,
It
lid
is.
lid.
It is periorbital myxedema.
Okay.
Mm.
Periorbital makes edema.
Mm.
Mm-hmm.
Okay.
Mm-hmm.
So remember. Okay. Don't see the slab part. This we'll do separately.
Okay.
Interpreting TFT is an art.
Mm-hmm.
Okay. So hypothyroid will be the exact opposite.
Yep.
There'll be cold intolerance, weight gain.
Mm-hmm.
Then there'll be periorbital edema, constipation. Because basically
Mm-hmm.
everything reduces, GI motility reduces, appetite reduces, metabolic rate reduces, therefore there's weight gain.
Yep.
Okay. The patient always is depressed, just like me. Oh shit. Okay. Then there's bradycardia and there's dyspnea on exertion.
Okay.
Okay. Peace. Hello.
Yeah.
What time is it for you guys at? Like 12?
It's no,
No,
it's
11,
uh,
10:47.
yes.
Mm.
You already sound tired.
But
Think of my condition. It's 1:17 a.m.
my God, you should be very tired.
And I sound more enthusiastic than you.
I am enthusiastic.
What?
I am enthusiastic.
Good, you better be. Okay,
Yeah.
fine. So we'll do first hypothyroidism, like conditions related to that. Sai, what is Hashimoto's?
So Hashimoto's, uh, it's a chronic autoimmune condition.
Mm-hmm.
Uh, I think it's a
That is that. Basically, I think there's destruction of your T3 and T4 because of antibodies. Hashimoto's thyroiditis, no?
Yeah, okay. Tell, continue.
So, so you'll have hypothyroidism.
Okay.
What else
Then,
do you want?
okay,
Like,
how will you diagnose? How will you
so Hashimoto's,
treat?
you have to give steroids because
Mm-hmm.
it's autoimmune. Then
Mm-hmm.
mainly you will look at TSH levels. TSH will be high, T3, T4 will be low, and you I think also look at TPO. Wait, is it against? No, it's anti-TPO antibodies. No,
Mm-hmm.
Hashimoto's is it destroys your thyroid peroxidase. So you will
Yes.
have low T3, low T4, and more TSH. And treatment you will give steroids.
Okay. What else? Only steroids?
And you'll give this one also, levothyroxine. T3,
Yeah,
T4 you'll
because
give.
we need to supplement
Yeah.
the patient with this one. No.
Hmm. Hashimoto.
Correct. Okay. Anything else? Will you do surgery?
Hashimoto. Thymectomy.
Th-
You'll remove thymus.
Why?
I thought that was the reason for immunity, no?
Are you mad?
Then what do you do? Do you do surgery? I don't know.
Do you do surgery? That's what I'm asking.
If there is goiter, then you will do.
Mm-hmm. What are it?
If there is goiter, then you will do.
uh,
No.
Mhm. So you don't do
Yes.
surgery.
Sai, you were
Right.
telling something.
sorry.
You were saying something.
Uh, yeah, I mean it's a case of hypothyroidism, no? So I don't think surgery.
See, what is the problem in Hashimoto's? Basically, you have auto antibodies.
Yeah, lymphocytic infiltration.
Yeah, okay. You have antibodies. So, will removing the thyroid gland help?
Mm,
Exactly. So, you don't do surgery.
mm,
Okay. Remember, histology, you see Hürthl cells, which are basically lymphoid aggregates.
mm,
Okay. Also, there's something called hashitoxicosis. You know what that is?
Initially, in the initial stages of your Hashimoto's thyroiditis, there will be lot of release of because there destruction of basically there will be destruction of your follicular cells. These
Yeah.
follicular cells will eject T3, T4. So initially there will be
Yes.
hyperthyroid state.
Yes. Then why does hypothyroidism occur after that?
You have destroyed follicular cells, no? So
Yeah,
they
which
will,
cannot regenerate.
yeah,
Therefore, you have a prolonged hypothyroidism.
yes.
Okay. So, how do you diagnose? You can get the antibodies tested or you can do a histopath.
Okay.
Okay. 1 second, Anam is calling. Yeah, bro. On the group, no, I didn't see it. Mm. 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 Hmm. Fill that form, apply of. Yeah. Yeah. Mm. Okay. Wait, bro. One sec. I'll call you back. I'm a little busy. Mm. Hello.
Yeah.
Sorry. Yeah, what was I telling? Yeah. So that's why. So initially, where was I, bro? Yeah. One
You were
second.
telling
First of
about
all, what antibodies are there?
uh, anti-thyroglobulin.
Anti-TPO and anti-thyroglobulin.
Oh, there's one more.
The
Anti-TPO and anti-thyroglobulin.
Okay. There's also an antibody against the thyroid receptor itself.
uh,
Okay.
Okay.
so TSH receptor.
Yeah.
Okay.
Okay. TSH receptor, TPO, as well as thyroglobulin. Correct. Okay. Yeah. So how will you? So the patient will present to you with features of hypothyroidism. All this, and he may have diffuse goiter. Okay.
Mm-hmm.
So that's why whenever a patient comes to you with goiter, uh, so medically there is no way you can reduce the goiter. Okay. If you want to, like, if there are cosmetic issues or whatever with the goiter, you have to get it surgically removed. But you should never do a surgery without doing a biopsy. This is the reason.
Okay.
Okay. Okay. And yeah, you'll see the Hurtle cells, which is basically the lymphocytic
Diagnosis.
infiltration.
Okay.
Okay. Now tell me, if there is long-standing Hashimoto's, is there a risk for developing a cancer?
Yes.
Yeah. Papillary and follicular thyroid carcinoma can present.
Mm. Yeah.
Okay. Now tell me, how will you manage? So yeah, you said thyroxine replacement.
Yep.
Okay.
Mm-hmm.
Monitor the TSH levels.
Mm-hmm.
Okay. Apparently, according to the latest guidelines, if there's goiter, you can do surgery, which I think is very stupid. Okay, but you can.
Mm-hmm. Okay.
Fine. Now we'll do subacute granulomatous thyroiditis or dequervans thyroiditis. Okay.
Mm-hmm.
So yeah, so basically what happens in these people is there's an infection.
Mm-hmm.
It's preceded by a viral infection.
Yeah.
Okay. So basically, suppose the patient has a viral upper respiratory tract infection. Okay.
Mm-hmm.
Around 4 to 6 weeks after that, the lymphocytes will infiltrate the gland.
Okay.
The lymphocytes which are produced as a result of inflammation will
Mm-hmm.
infiltrate the gland and
Okay.
cause a painful enlargement of the neck.
Mm-hmm.
Remember, in this is the only condition where you have
Mm-hmm.
a tender enlargement.
Okay.
Everywhere else, thyroid swellings are usually non-tender.
Yes.
Okay. So now,
Mm-hmm.
once the lymphocytes infiltrate the gland, they destroy the follicular cells.
Yes.
Okay.
Mm-hmm.
So, because again they destroy the follicles, there is a brief phase of hyperthyroidism, just like Hashimoto's.
Okay.
That's followed by hypothyroidism.
Okay.
Okay. Now, once the infection subsides, the patient will again become euthyroid within 3 to 4 months.
Oh.
Okay.
Yeah.
It made sense. There's hyper, euthyroid, and then followed by hypothyroidism again.
Hmm.
It is self-limiting.
Hyperthyroid,
So you just, sorry.
hyperthyroid, hypothyroid, then euthyroid, right?
Yeah,
Hmm. Okay. This is three
got
to
it.
four months it takes.
Yeah, till basically all that
Mm-hmm.
lymphocytes have reduced.
Okay.
Okay, peace.
Yep.
Okay, great. Next we shall do Riedel's thyroiditis.
Okay.
Okay, this is also called invasive fibrous thyroiditis. We will see why.
Okay.
Okay, it's basically associated with this IgG4.
Mm-hmm.
So all the conditions associated with that, like your retroperitoneal fibrosis, your autoimmune pancreatitis, and all of those things. Okay,
Mhm.
so it's basically a part of a systemic fibrous disorder. So, what
Okay.
other fibrous disorders do you know? Systemic
Fibromyalgia,
fibromyalgia. Okay,
fibrous disorders. Mm.
fibrocystic
Kidney disease.
kidney disease. Okay, you've heard of something simpler? Peyronie's disease,
Yeah, Al
uh,
Clinton.
Dupuytren's contracture.
Yes.
Mm.
Okay, those are the normal things that it's usually associated with. Okay, fibrosis of the gland occurs, right? So that's
Yep.
why the thyroid gland, when you palpate, will be hard, woody.
Heart and body. Okay.
Okay, what do you think will be a differential diagnosis of this?
Malignancy.
Yeah, which one? Anaplastic cancer.
Okay.
Okay,
Anaplastic.
you
Mm.
differentiate that by obviously doing a true cut biopsy. Why true cut biopsy and why not an FNAC?
Mhm. Because it is fibrosis, no FNAC, you will not be able to get anything.
Why?
Any fibrosis, you don't get, no,
Why?
in aspiration.
Why?
It's fine needle in aspiration.
No, you can see. See, basically, you're suspecting a cancer, no?
Mm-hmm.
So you want to look for basement membrane invasion,
Oh, okay.
right? That's why you always take a true cut biopsy. By the way, guys, do you know? True cut is actually the name of the brand,
Oh,
like Xerox.
oh, okay.
The
What is it
actual
called
thing,
then?
it's called core needle biopsy.
Core needle biopsy.
So you should always say that.
Mm.
Mm, okay.
You know who taught me this?
Ooh.
Vishnu.
Vishnu.
Sai will tell you.
Okay.
True love.
What? What did he say?
I said true love.
Q. Asshole. One-sided true, maybe. I don't know.
Mhm. Okay.
Hmm.
Next.
Okay. So again, there's a painless enlargement of the gland.
Mhm.
Okay. Now, how will the patient present to you?
Mhm. Painless. In
See, there is fibrosis. Will it
yes.
limit itself just to the thyroid gland? No.
No.
It's obviously going
Mm.
to extend beyond that.
We
Okay.
Mhm.
complain of dysphagia,
Dysphagia. Okay. Yes. If there is
dyspnea,
esophagus involvement, there will be dysphagia. Next.
dyspnea,
Dyspnea. If it involves a trachea, there'll be dyspnea. Okay. Next.
mm, hoarseness of the voice,
Yeah. That is due to
the recurrent laryngeal nerve involvement.
yes. Yes. Involvement of the recurrent laryngeal nerve. Correct. So your symptoms are dysphagia, dyspnea also can lead to stridor, and hoarseness of voice due to involvement of recurrent laryngeal nerve.
Mm.
Okay. How will you treat this condition?
I think you remove it, no? Like you have to do
Remove it.
surgery.
Okay. If
That
there
is
is
the
fibrosis that is spread to the trachea, esophagus, and all,
mm,
remove those also.
some release you will do.
Mm-hmm.
You see, medication I don't think will help much.
See, you can give steroids,
Um,
and also you can give tamoxifen, which is a selective estrogen receptor modulator.
okay.
How do you think
Uh,
that will help?
Estrogen increases thyroglobulin, right?
Yes. So you're thinking correct. Continue.
The T3 and T4.
T3 and T4 will be bound. Therefore,
what is the reason for fibrosis?
what is the reason for fibrosis? It's IgG4 mediated. So
IgG4. But what could be causing fibrosis? Is it like part of inflammation that is fibrosis? That is leading to fibrosis?
Yeah,
Okay, so if I reduce inflammation, so I'll give steroids, that is going. Then how is tamoxifen helping?
you tell.
Is that also reducing production of IgG4?
Is that also?
Is that in any way reducing production of IgG4?
You know.
It's
No.
an estrogen receptor modulator, no?
Hmm.
Yeah. So it is increasing estrogen.
Yeah,
Okay.
and in the previous slide, we saw that during pregnancy
Mm-hmm.
and OCPUs, this estrogen has an effect on TBG.
Mm-hmm.
It increases the concentration of TBG.
Mm-hmm.
So does that have something to do with it?
No. Can unless you can no, but unless you can think of anything.
I'm just guessing because
No, no, no. See, basically, selective estrogen receptor modulators
hmm,
uh, um, release something called transforming growth factor beta.
okay.
Okay, that inhibits fibroblastic proliferation.
Okay. What does it release?
Sorry,
What does it release? What do they release?
they release something called transforming growth factor beta.
Okay.
Transforming growth factor beta.
Mm-hmm.
Okay,
Mm-hmm.
that inhibits
Okay.
fibroblastic proliferation.
Okay. Got it.
Okay, that's how it's used in Riedel's thyroiditis.
Hmm.
Did it make sense?
Yeah,
Yeah.
yeah.
I
Okay.
was thinking, see, somehow it has to inhibit fibrosis.
Hmm.
So what is that?
Yeah, yeah. Kaushik, though, his imagination.
I think that, mainly in this, there is main pathology is only fibroblastic proliferation. No,
Yeah, correct.
that's all. Anyway.
Hmm.
So will they do surgery for this by any chance?
So, if the thyroid has become so fibrous that it is causing pressure on the trachea or the esophagus or anything, you can just do an isthmusectomy. So, just remove the isthmus
Mhm.
to relieve pressure,
Okay.
because removing the thyroid is not going to help,
Mm. Yeah.
right?
Yes.
Okay. Yeah. Congenital hypothyroidism.
Okay.
Okay. Uh, so see, it's congenital. Okay.
Mhm.
So think.
Congenital
Uh,
hypothyroidism.
yeah.
I feel like it is mother will have less T3, T4. Mother
See,
will be thyroid.
okay. So first of all, the kid is born without a thyroid gland
Yes.
for some reason. That's
Okay.
the easiest thing.
Yeah.
Thyroid gland dysgenesis, agenesis.
Mm-hmm.
Okay, or like a hypoplasia.
Yes.
The other option is the hormone that's produced is not normal,
Yeah.
or there is some mutation in the enzymes, like for example thyroid peroxidase or whatever,
Yeah.
which is therefore causing what do you call um hypothyroidism. Sorry, one second, guys. Yeah, right. Hello, hello,
Yeah,
hello.
yeah.
Yeah. So those are the like common causes. Either you don't have a thyroid gland,
Mm-hmm.
Mhm.
or you have like an ectopic gland which isn't producing sufficient thyroid hormone,
Okay.
or the hormone that's produced is like due to mutation in the enzymes causing the hormone release, the hormone is not normal.
Yeah.
Okay. Iodine sufficient areas. I think that's a typing error. I think they mean iodine deficient areas.
Yep,
Okay.
it's deficient.
Iodine like deficiency is usually this one. Okay. Now Kaushik said regarding the mother. See, there's something. Suppose a mother has antibodies, maternal antibodies, which are the TSH receptor blocking antibodies, which is seen in.
Uh, wait.
Come on,
TSS receptor blocking.
I mentioned it. I think yeah, I did.
Graves. No, that you will have hyper
Wait. So what's the question?
Hashimoto's.
TSH receptor blocking antibodies is seen in which condition in adults?
TSH receptor blocking antibody.
Hmm.
Hashimoto, no?
Yeah, correct. Correct.
Hashimoto's.
So that could cross the placenta
Mm-hmm.
and enter
Mm.
the fetus.
Okay.
Okay.
Okay, and therefore cause transient. But remember, that's very transient.
Oh, okay.
Okay.
Okay, yeah.
Mm-hmm.
Then Pendred syndrome, we know
Yeah.
that also can cause this one. Okay, so uh, see, basically, uh, when do you think the kid will present?
After a week, uh,
Why? Why not at birth?
at birth, mothers will be there, no?
Yeah, the mother's thyroxine usually forms a protection. The kid will start presenting to you after a week.
Mm.
Yeah.
Okay, all the same. What do you call same symptoms of any hypothyroid patient. Only thing is the kid will be pot bellied and there will be protruding umbilicus. This is basically due to
In umbilicus, pot belly, accumulation of fat.
yeah. There is reduced BMR. No,
Yep.
that's all. Okay. And there will also be like a prolonged jaundice in the kid
Uh,
because basically everything slows down in hypothyroidism.
Mm. Mm.
Okay.
the physiological jaundice will stay for longer.
Mm. Okay. So suppose you want to. So now that you've read this, if you decide to
Mhm.
have a kid tomorrow
Okay.
and you want to make sure this doesn't happen, when
Mhm.
should you ideally check for TSH?
TSH before pregnancy, you should test check.
Hey, Amma, in the baby.
Oh, in the baby,
Uh,
ideally, like as soon as I think one day after birth and after 1 week.
yeah,
After 1 week.
around 2 to 5 days after birth, you should check. Between 2 to 5 days of birth, day three is most ideal.
Okay.
Okay.
Mm.
Okay. And suppose so once you like once the patient has the symptoms along with along with a TFT, you can also get one X-ray done, and you'll see there'll be delayed osseous maturation. The bones won't be completely formed. Basically, they won't have fused, etc.
Because of hypothyroidism.
Yeah.
Mm.
Okay.
Mm.
If you want, you can do a thyroid. What do you call scan? Like if there's agenesis and all,
Mhm.
Mm.
you need to do a thyroid scan, right?
Yeah.
To see it. If you're suspecting an ectopic thyroid, what will you do?
Ectopic thyroid. That iodine uptake you do, no?
Yeah, iodine uptake you can do, but in kids, they normally just do PET CT.
Oh, okay.
Okay.
It will glow.
Yeah.
Mm-hmm.
Okay. Now, how will you treat?
You'll
How will you
give
treat?
you'll give thyroxine, no?
Yes.
T3T. That
Dose.
is
Dose.
25 micrograms. That's the starting dose that you get.
In adults.
It's based on body weight.
Yeah,
What is that body weight? Dude? 4 microgram per kg, no?
around
Something
that.
like
Yes. You give around 10 microgram per kg. Okay.
10.
So,
Okay.
yeah. So, now when do you start giving it?
After a week.
Whenever you diagnose, as early as possible, so that it doesn't cause delayed brain maturation.
Mm.
Okay.
Okay.
Mhm.
You have to your TSH should be normalized by a month.
Okay.
Okay, and the patient obviously has to take it lifelong.
Okay.
Mm.
Right.
Yeah.
Yes.
Yeah. Yeah. That's it. Wolf Chekhov, we know already.
Yep.
Mm.
Okay. Yes. Do you guys need a break?
No.
Can
Are you
we
sure?
continue? Can we continue tomorrow? Is it okay?
Are you tired?
I have to go. I have some work.
Say that.
Yeah.
Okay, we can continue tomorrow. No
Okay.
issues.
Wait.
Yeah.
Just
Yeah.
a second before we go. So I wanted to know